Thank you very much for inviting me. I didn't feel a little uncomfortable earlier when I wasn't sure if I was on the list of the wrong people that Carmen didn't talk to. This is how we handle off-label use in Germany. We have two ways. The left one is the official one, the green one. Formally, stakeholders can apply for that. Stakeholders are insurances, but lots of patients. And then there's this off-label commission, and I'm vice chair of this at the BfArM. However, the procedure is fairly lengthy. It takes up to 3 years. And if it's successful, then it's policy that it has to be paid by the insurance. But if not, then it can't be paid. So there's some risk in there. Of course, also as mentioned prior here, you can apply individually for the local insurance, and then it's up to the insurance to decide if they pay or if they don't pay. And if they don't pay, you may appeal for that. But again, it's really a hassle. And I'm also coming from hematology and oncology. Many people just don't have that activity and that level of incentive to really do that. So Prof Lauterbach, when he was Minister of Health, decided that he would try to have a shortcut and establish a separate commission, an expert commission, and many of the names that you are seeing here are also in the room. So we got the task to decide if one of these drugs might be feasible and might fulfill criteria for an off-label use, and then doing it in a shorter time than usually, and we started almost a year ago. So we decided to do it first on an evidence-based research format. We asked the WIC2 Institute, which is an HTA institute in Leipzig, to perform this analysis, and we had the following steps. First level was looking at long COVID, post-COVID, and the specific symptom or syndrome which was associated to be asked for. That was level 1. Second level was if the institute could not identify any research at sufficiently high level, then they could extend this research to patients with ME, CFS, or with spots, even not in the context of long or post-COVID. And later on, we decided not only to talk about treatment, but also to add prevention or prophylaxis of long COVID and post-COVID. And this is not new to all of you. The first result was very deceiving. They looked in more than 1,600 Medline publications, and on the left down here, they came up with 41 trials which they could really include in that analysis. So there really is, as we discussed all morning now, a severe lack of serious and profound research on the clinical level. If we put that into a graphic, this is the number of trials which they could identify according to our level 1 or level 2, kind of what we were asking for. So the early is the low. It's always in the 1-digit range. So there's almost none of the research is in more than 10 clinical trials, and very few are green, very few are level 1, and the most one have level 2 or 3 evidence. And again, some of them, also which is shown on the previous slide from Dr. Stingel, there is no clinical trials except not for statins or aripiprazole. So now the next slides are a little busy, but I thought I heard this morning that some of you are very experts in that field, so I allow myself to really show the data and hope that I don't lose most of you. So the first one was ivabradine, looking at patients with COVID-associated POTS. There is a pre-post cohort trial, including 55 patients, analyzed pre and post the exposure to the drugs. They used ivabradine at 5 milligrams daily. And the important point is down here, that more than 3/4 of the patients experienced a significant improvement of their health. If we combine that with a previous trial, which was performed in that group of patients without the context of post or long COVID, we can add this crossover RCT with 22 adults with POTS, and again we have the same result. Quality of life increases, heart rate is increasing. So the first conclusion of our group is that we will recommend ivabradine for patients with COVID-19 associated POTS. I definitely underline, we say we will recommend it. It's a Federal Joint Committee which has to decide. We don't decide, we make an expert recommendation. Number 2, vortioxetine, probably some of you know it. It's a so-called multifunctional antidepressant. It doesn't belong to the usual categories of SSRI, so it's called multifunctional because of different ways of action. In this area, we have one fairly well-performed randomized clinical trials, including almost 150 patients. They only included patients with post-COVID. There were a number of post-hoc analyses to look in more detail into 2 more subgroups. The most important point are the 2 here. There's a significant improvement of cognitive function and a significant improvement of depressive syndromes, which can be induced with the treatment of vortioxetine. So looking this together, we recommend that, again, this should be an in-label use for cognitive patients with this disease, with post-COVID, and with cognitive function and depressive symptoms. Number 3, agomelatine. Again, it's closely related to melatonin, but it has a higher affinity to the melatonin receptor. So that's why it's approved as a separate drug. Again, this is not a randomized clinical trial, but a crossover RCT, so it's a little lower degree of evidence. Again, those are 62 patients. Importantly, there was an intervention group 1 and 2, and probably it's easier if we just go to this small graph down here. There was a randomization. One group of patients initially got agomelatine. This is the solid line. And you saw there was quite a significant degree of success in lowering the fatigue score, really going from about 60 to between 30 and 40, which really is a significant improvement, if all of you know who deal with these patients and with this scale. The group that initially started with melatonin could switch after 12 weeks, and then you see the same effect. So it's about the same degree within those areas of confidence of interval. So again, obviously, there is a positive effect of agomelatine for fatigue, on fatigue. There was a confirmatory study done in Russia. However, it's not fully published yet as a paper, but they did a prospective observational study on 103 patients. They came up with similar results, although since it's not randomized, it's weaker. But what's quite important for us, that they also did not see any adverse events. As Dr. Stingel already mentioned, we always have to do not to do harm on our patients. So our conclusion is number 3. We'll recommend agomelatine for patients with fatigue. Number 4, also mentioned before, low-dose naltrexone. You're well aware. This is a well-established and an in-label drug, but in a much higher dose of 50 milligrams for patients with opioid dependency. If you use it as a low dose, which is in this trial 1, 2, and 3 milligrams, and you give it in these patients with fatigue, there is a significant improvement in all categories of fatigue and also in some other long COVID-associated symptoms. So again, we feel, although this is a pre-post cohort, it's not a randomized trial, there is some evidence that low-dose naltrexone will work. Many of you are aware. The strongest clinical trial on this is still running. It's performed in British Columbia and Vancouver. It should have been finished in January. Now they aim to finish the 160 patients to be recruited in August, and we'll make our recommendation depending on this clinical trial. If this is a positive trial, we're in close contact with Dr. Naik, then we'll recommend also low-dose naltrexone in this group of patients with fatigue. Last drug. Metformin may be an efficient drug to prevent severe long COVID or post-COVID syndrome. This is the strongest of our clinical trials that we have been analyzing. The intervention group had more than 600 patients. The control had the same, more than 600 patients. And just look at this. If you give it within the first 3 days of a COVID-19 infection, then the degree of patient that develops long COVID is significantly lowered. Most importantly, it should be done within the first 3 days of an infection, and patient should be selected based on a BMI of more than 25, because that was the inclusion criteria. We have discussed it extensively with Ute Behrens, and this recommendation will also be given by the Commission, and it will be extended to adolescents over the age of 16, because we feel biological there is no significant of it. I heard the bell. This is the almost last slide. We are not without weapons in patients with long and post-COVID. We have approved in-label drugs for all of these symptoms, and we think with the Commission now we can add this picture, we can add drugs for POTS, tachycardia, fatigue, depression, and also for prevention and prophylaxis. Thank you for your attention.
Thank you. I see a question up there.
Microphone is migrating.
It was the longest way for the microphone ever. Thank you. How would you explain that there are such big differences between the drugs that you put on the list in Germany and those appearing on the Austrian off-label list? Is that due to a different scientific evaluation or due to political demands?
It's a basic difference between evidence and eminence-based research. Am I completely wrong? Well, this is the evidence. And we also been doing the same, just asking people like that. But the whole procedure in Germany, well, we have a solidarity-financed health system. So if we have off-label, I'm an oncologist. We have more than 100 off-label indications, and we have fairly well-structured access to off-label drug, and that has also been used for long COVID and post-COVID. On an individual basis, it seems easier to live in Austria, but in a solidarity system, solidarity also finance system, I think we don't have really another access than the one that we chose.
Okay, next question.
But I'm open to discussion about that.
So there's the perception in the general practitioners that when you have COVID, cannot use the normal indication of the drugs, because when you have COVID, post-COVID disease, it's a new disease, and let's say if you have hypertension due to post-COVID, I make it very simple, or you have pain, you have a new disease. We have to wait for prospective studies. Is that really true, or when we have a disease in, let's say, with other infections or with oncology, we can treat it in an indication which has been described?
Well, thank you very much for clearing that. I didn't make it very clear on the last picture. All the blue points that I match on this, what we call treatment navigator, are in-label use of pain medication, of asthma, of autoimmune disease, immunoglobulins, and immune reaction. And we had agreed on that last summer already. So we only focus on those that we consider to be off-label. And we have this treatment navigator. It's an open space access of the so-called BfArM homepage, also the Ministry of Health. And there are more than 30 drugs, exactly those that you listed. They are all, in our view, they're accepted, and the insurances agreed to that. So we are not without weapons in that field, but we add some. So I exactly had the same discussion which we had in Germany. They say, like, if you have a pain within the context, no, it's pain. So I think you have to prescribe the drugs. Still, you have to consider side effects, which may be quite specific, of course, for these patients. So we did this treatment, what you call navigator, but we also underlined the potential specific side effects to be considered in patients with CFS or long COVID.
So is there a risk that if I prescribe one of the blue box medications and I have a diagnosis documented, which documents this diagnosis, then I have a risk to get regress from the insurance company?
No, because it has been agreed on, and since we've been doing this, which is now almost a year, I had no complaint, null, zero.
Yeah, I think I'm same, but I just want to.
Okay, no, thank you very much.
Maybe a very short comment on the timeline, because everybody here is interested in the timeline.
Sorry.
About the timeline, when
I thought
when do we get the
about my timeline to be finished. Yeah.
the timeline of the off-label list?
We're finishing this in June, and we hope that we can get it to the GBA prior to the summer vacation. So then it's up to the GBA. It'll take another month, several months to do it, but I think our job is done.
Okay, thanks a lot for everything.